Alright, now we're going to go over pain management, the clinical nursing skill portion of the book. We're going to read certain pages, these pages right here. So let's just go ahead and get on jumping in and starting with this, and then we might do a review, depending on how we're feeling.
Pain is the most common reason that people seek healthcare, yet it is often under-recognized, misunderstood, and inadequately treated. Data from the 2012 National Health Interview Survey, NHIS, found that an estimated 25.3 million adults, 11.2%, experience daily pain, i.e., they had pain every day for the 3 months before the survey, NIH, 2015b. A patient is the only one who knows whether pain is present and what the experience is like. Your role as a nurse is to recognize the unique nature of pain for each patient and help select appropriate therapies. The skills in this chapter emphasize the importance of using critical thinking along with an integrated approach that considers both pharmacological and non-pharmacological therapies in managing a patient's pain. Standards of care. The Joint Commission, 2016 Patient Identification. American Pain Society. The two types of pain that you observe in patients are acute, transient, and chronic, persistent, which includes cancer and non-cancer pain. The most effective pain management combines pharmacological and non-pharmacological strategies. There are 3 types of analgesics: 1. Non-opioids and non-steroidal anti-inflammatory drugs, NSAIDs, 2. Opioids, traditionally called narcotics, and 3. Adjuvants or co-analgesics, example antidepressants and muscle relaxants, that enhance analgesics or have analgesic properties. Timely analgesic administration before a patient's pain becomes severe is crucial for optimal relief. Pain is easier to prevent than treat. In most situations, administration of pharmacological agents around the clock, ATC, rather than on an as-needed, PRN, basis is preferable. The American Pain Society and the American Association of Pain Medicine, 2009, supports ATC administration if pain is anticipated for most of the day. The current pharmacological approach to acute and chronic pain management is to provide multimodal analgesia, which combines drugs with at least 2 different mechanisms of action so pain control can be optimized. Make every effort to include complementary/integrative methods, which generally do not require a healthcare provider's order. Check agency policy. Complementary strategies provide an opportunity for a patient to assume an active role in achieving a higher level of comfort and in some instances freedom from pain. NIH, 2015a. Patient-centered care. Pain management should be patient-centered, with nurses practicing patient advocacy, patient empowerment, compassion, and respect. Caring for patients in pain requires recognition that pain can and should be relieved. Teaching your patient and his or her family about pain treatment and having an attitude of dignity and caring will allow you to individualize a patient's pain control plan. Pain is unique to each individual. It is important to recognize all factors influencing a patient's pain and integrate them into an individualized plan for pain management. A timely, factual, and accurate pain assessment requires you to work closely with patients and their families. Be objective, listen carefully, and assess any symptoms that a patient expresses. Effective communication and caring are key to gathering all the information needed to accurately determine the character of a patient's pain and its impact. Knowing these factors will help you intervene effectively to manage your patient's pain. A patient's culture affects his or her recognition of pain, expression of pain, when to seek treatment, and which treatments are desirable. For example, research has shown that minority patients are at high risk for poor pain outcomes. When patients belong to a culture that is different from that of their healthcare provider, the provider faces additional challenges, compared with patients from the same culture, to successfully assess and manage the patient's pain. Narayan, 2010. Explore a patient's beliefs about pain/discomfort. For example, cultures with a holistic worldview of health and illness mix religious/spiritual, natural, and the supernatural in their belief systems. Use interpreters to explain pain tools and help patients report their pain as needed. The International Nurses Society on Addictions, INNSA, and the American Society for Pain Management Nursing supports the position that every patient with pain, including those with substance use disorders, has the right to be treated with dignity, respect, and high-quality pain assessment and management. Oliver et al., 2012. When patients have pre-existing chronic painful conditions, a complete preoperative pain evaluation is an essential component to identify pain control interventions to manage perioperative and postoperative pain. ASA, 2012. Evidence-based practice. One of the more challenging conditions in pain management is chronic low back pain. In a systematic review by Camper et al., 2015, 41 clinical trials involving patients who had duration of pain of more than 1 year and who often had failed previous treatment were examined. Patients received interprofessional rehabilitation, which involved a physical component and one or both of a psychological component or a social or work-targeted component. The strength of the 41 research studies varied in quality. The results showed that interdisciplinary biopsychosocial rehabilitation interventions were more effective than usual care, moderate quality evidence, and physical treatments, low quality evidence, in decreasing pain and disability in people with chronic low back pain. For work outcomes, interdisciplinary rehabilitation seems to be more effective than physical treatment but not more effective than usual care. A biopsychosocial approach to care is an individual-centered model that considers the person, his or her health problem, and the social context. Biological refers to the physical or mental health condition. Psychological recognizes that personal/psychological factors also influence functioning. Social recognizes the importance of the social context, example work, family, pressures, and constraints on functioning. Safety guidelines. Monitor patients who receive opioids, by any route, for signs and symptoms of oversedation and respiratory depression. Excess sedation, difficult to arouse, precedes respiratory depression, especially in opioid-naive patients, i.e., patients who are not chronically receiving opioid analgesics on a daily basis, AAPM, 2013. Using a standard sedation scale can prevent respiratory depression by observing and intervening for oversedation, Box 16.3. Box 16.3. Sedation scale asterisk. S equals sleep, easy to arouse. 1 equals awake and alert. 2 equals slightly drowsy, easily aroused. 3 equals frequently drowsy, arousable, drifts off to sleep during conversation. 4 equals somnolent, minimal or no response to physical stimulation. Remember, sedation precedes respiratory depression. Asterisk. Monitor activities such as standing, ambulation, and transfer to a chair if patient has received an opioid. Assess patient's blood pressure, pulse, and respirations before initiating activity. If a patient has undergone an outpatient procedure, educate patient and family caregiver about precautions. Patient cannot drive for 24 hours. Caregiver may need to provide help with ambulation or take precautions to make home environment safe. Monitor for potential side effects of opioid analgesics and recommend or institute supportive measures. Example, addition of stool softener or high fiber diet for side effect of constipation. Epidural analgesia intravenous. 4. Infusion lines should be labeled clearly and identified as such to prevent accidental connection with tubing of a different type. Example, tube feeding, blood infusion line, Robotham et 2010. Follow these guidelines, ISMP, 2013. Limit access to epidural lines to healthcare providers with proper education and competence. There can be serious ramifications of misconnections, infections, occlusions, or misadministration of medications. Trace an epidural catheter line from the access site into the patient's body all the way to the end source of an infusion or capped access port before you connect or reconnect tubing or administer a medication. Communicate any practice changes, including dressing location, type of tubing and connectors, with all members of the healthcare team who are providing care to the patient. Patients currently receiving opioids for chronic pain often require higher doses of analgesics to alleviate new or increased pain. This is tolerance, not an early sign of addiction. AAPM, 2013, Box 16.4. Confer with healthcare provider who might not be aware of at-home dosages. Be aware of individualized dosages and ensure that all caregivers are informed. Opioid exemplar. Box 16.4. Terminology related to the use of opioids in pain treatment. The American Society for Pain Management Nursing, ASPM, has released a formal position statement. Every patient with pain, including those with substance use disorders, has the right to be treated with dignity, respect, and high-quality pain assessment and management. Failure to identify and treat the concurrent conditions of pain and substance use disorders will compromise the ability to treat either condition effectively. Oliver et al., 2012. Common conditions involving use of opioids in pain treatment include the following. Physical dependence. A state of adaptation that is manifested by a drug class, specific withdrawal syndrome produced by abrupt cessation, rapid dose reduction, decreasing blood level of an opioid, and/or administration of a drug that can act as an antagonist. Addiction. A primary, chronic, neurobiological disease, with genetic, psychosocial, and environmental factors influencing its development and manifestations. Addictive behaviors include one or more of the following: impaired control over drug use, compulsive use, continued use despite harm, and craving. Drug tolerance. A state of adaptation in which exposure to a drug induces changes that result in a diminution of one or more of the effects of the drug over time. Drug-drug interactions, including enhanced or reduced effects or side effects, often occur with the multiple drug use required by people with chronic pain. This practice is termed rational polypharmacy or multimodal analgesia, Menujan, 2010, Passero and McCaffrey, 2011. No agency policy for frequency of pain assessment and timing for follow-up assessments. The first 24 hours on opioids requires frequent assessment, at least every 4 hours. Skill 16.1 Pain assessment and basic comfort measures. An accurate and comprehensive pain assessment is necessary to identify the nature of pain, the patient's perception of pain, and the effects on his or her lifestyle, as well as offer clues to the cause of the pain. A thorough assessment will allow you to arrive at proper nursing diagnoses and select appropriate pain relief therapies. Effectively managing a patient's pain does not necessarily mean eliminating it, but it does mean getting it to an acceptable level for him or her. Pain management requires you to work with a patient and family to prevent pain whenever possible and identify an acceptable intensity of pain and level of other factors, especially sleep, that allow maximum patient function. Use of the nursing process allows you to recognize distinct and unique differences in patient perceptions and responses to pain. The nursing process guides you in learning to know a patient and develop an individualized plan of care. Delegation and collaboration. Assessment of a patient's pain cannot be delegated to nursing assistive personnel, NAP. The NAP may screen patients for pain and provide selected non-pharmacological strategies, example back rubs, heat or cold application, as instructed by the nurse. The nurse directs the NAP to eliminate environmental conditions that worsen pain, example an excessively warm, noisy room. Provide maximum rest periods for patient, a written schedule for caregivers to follow is ideal. Turn and place patients in a position of comfort at least every 2 hours or remind patients to turn themselves. Encourages patient to use a pillow for splinting if needed. Observe for and report to the nurse behavioral signs of pain for patients who are unable to self-report, see box 16.2. Ask a patient to describe pain using a pain intensity scale chosen by patient and nurse. Report in a timely manner to nurse any patient reports of pain intensity above predetermined goal and nonverbal behavior suggestive of pain. Screen for pain during patient transfer or other activity that might provoke pain. Equipment. Pain rating scale, check agency policy. Step/rationale. Assessment. 1. Identify patient using at least 2 identifiers, example name and birthday or name and medical record number, according to agency policy. Ensures correct patient. Complies with the Joint Commission standards and improves patient safety, TJC, 2016. 2. Assess patients' risk for pain, example those undergoing invasive procedures, anxious patients, those unable to communicate. Allows you to anticipate patients' needs and intervene in timely manner, possibly preventing pain. 3. Ask patients if they are in pain. Observe for nonverbal indicators of pain, ask significant others if they believe patient is in pain, Hare et al., 2011a. Older adults and patients from various cultures may not admit to having pain. Try using other terms such as hurt or discomfort, or use professional interpreter if language difference exists. There is no objective test to measure pain. Accept patient's self-report of pain, Paciro and McCaffrey, 2011. Recognizes that cultural differences exist in how pain is expressed. 4. Perform hand hygiene. Examine site of patient's pain or discomfort when possible. Inspect, discoloration, swelling, drainage, palpate, change in temperature, area of altered sensation, painful area, areas that trigger pain, and assess range of motion of involved joints. Percussion and auscultation can help to identify abnormalities, example underlying mass or lung crackles, and determine cause of pain, see chapter 6. When assessing abdomen, always auscultate first and then inspect and palpate. Reduces transmission of infection. Reveals nature of pain and directs you toward appropriate interventions. 5. Assess physical, behavioral, and emotional signs and symptoms of pain. A. Moaning, crying, whimpering, groaning, vocalizations. B. Decreased activity. C. Facial expressions, example grimace, clenched teeth. D. Change in usual behavior, example less active, irritable. E. Abnormal gait, example shuffling, and posture, example bent, leaning. F. Guarding a body part. G. Diaphoresis. Signs and symptoms may reveal source and nature of pain. Nonverbal responses to pain are useful in assessing pain in patients who are cognitively impaired or nonverbal. H. When appropriate, assess for increased blood glucose level reflecting stress of unrelieved pain. The stress of unrelieved pain causes the endocrine system to release excessive amounts of hormones, especially cortisol, and decreased levels of insulin, Paciro and McCaffrey, 2011. I. Decreased gastrointestinal, GI, motility, constipation, nausea, and vomiting. Signs and symptoms of pain originate from involvement of visceral organs with stimulation of the parasympathetic nervous system, which decreases gastrointestinal, GI, tract activity, Drew and St. Marie, 2011. J. Insomnia, anorexia, and fatigue. K. Depression, hopelessness, anger, fear, social withdrawal. Depression frequently occurs in patients with chronic pain and increases perception and intensity of pain, Drew and St. Marie, 2011. L. Concomitant symptoms, symptoms that often occur with pain, example headache, constipation. Note, constipation is common with opioid use. Multiple symptoms increase complexity in care of patient. Clinical decision point. Physiological responses, example tachycardia, hypertension, to acute pain are of short duration and return to normal within minutes. Be aware that with persistent pain a patient does not usually exhibit physical signs and symptoms. Never use physiological responses alone to determine pain therapy selected, even with acute pain. Paciro and McCaffrey, 2011. 6. Assess characteristics of pain. Follow agency policy regarding frequency of assessment. Use the PRIST pain assessment. Guides clinician in collecting complete information about patient's pain experience. A. Provocative/palliative factors, example what makes your pain better or worse. Consider patient's experience with over-the-counter, OTC, drugs, including herbals and topicals, that have helped to reduce pain in the past. Identifies nature and source of pain and what patient uses to reduce discomfort. Combination of interventions is often most effective approach to pain relief. B. Quality, use open-ended questions such as tell me what your pain feels like. Helps to determine underlying pain mechanism, example somatic versus neuropathic pain. C. Region/radiation, example show me everywhere your pain is. Have patient use finger, if possible, to point out areas of pain. Identify location of pain and possible causative factors for acute/transient pain. D. Severity, use valid pain rating scale appropriate to patient's age, language skills, developmental level, and comprehension, see illustrations. Ask patient to rate pain at rest, before any intervention, and when he or she is moving or engaged in care activity. In the case of patients with dementia or those who have no verbal skills, use observational pain assessment scales such as the Pain Assessment Checklist for seniors with limited ability to communicate, PACSLAC, and the Pain Assessment in Advanced Dementia Scale, PainAid, TUI and JET, 2014, Zwakalen ETAL, 2006. Step 60. A. Pain Rating Scale. An appropriate pain rating scale is reliable, is easily understood, and reflects changes in pain intensity, Hare ETAL, 2011a. E. Timing, ask patient if pain is constant, intermittent, continuous, or a combination. Does pain increase during specific times of day, with particular activities, or in specific locations? Environmental stimuli such as loud noises, bright lights, strong odors, or temperature extremes sometimes alter patient's response to pain. F. How is pain affecting you, patient, regarding activities of daily living, ADLS, work, relationships, and enjoyment of life? Provides important baseline information to later gauge effectiveness of interventions. 7. Assess patient's medical history and type of therapy successfully used to relieve pain, example medications, OTC products, heat and cold therapies. History provides information for type of therapies to use for patient's specific situation. Many patients do not mention using OTC products for fear of being criticized or because they do not want them taken away. 8. Assess patient's response to previous pharmacological interventions, especially ability to function, example sleeping, eating, and other ADLS. Determine if any analgesic side effects are likely based on medication and patient's previous responses, example itching or nausea. Determines extent to which therapies have or have not been successful in the past, Gloth, 2011. Some side effects, especially itching that can occur with morphine, are often poorly tolerated by patient and indicate need to identify another analgesic. 9. Assess for allergies to medications, with focus on analgesics. Some patients with asthma or an allergy to aspirin are also allergic to other nonsteroidal anti-inflammatory drugs, NSAIDs, Morales ETAL, 2015. Nursing diagnoses. Activity intolerance. Acute pain. Anxiety. Chronic pain. Deficient knowledge regarding alternative pain therapies. Disturbed sleep pattern. Fatigue. Fear. Impaired physical mobility. Ineffective coping. Powerlessness. Readiness for enhanced comfort. Risk for constipation. Related factors/risk factors are individualized based on patient's condition or needs. Planning. 1. Expected outcomes following completion of procedure. Patient verbalizes full or partial relief from pain. Patient's self-report of pain is single most reliable indicator of pain, Paciro and McCaffrey, 2011. Patient displays nonverbal behaviors such as relaxed face and absence of squinting. Nonverbal behaviors can be valid and reliable indicators of pain and pain relief in the cognitively impaired, Hare ETAL, 2011a. Patient reports improvement in sleep, nutritional intake, physical activity, and personal relationships. Adequate pain relief usually permits patient to participate in usual ADLS. 2. Set pain intensity goal with patient, when able. Pain is unique to each individual. Patient sets individual goal for tolerable pain severity. Implementation. 1. Perform hand hygiene and apply clean gloves, if indicated. Reduces transmission of microorganisms. 2. Prepare patient's environment. Temperature suited to patient. Temperature and sound extremes can enhance patient's perception of pain. Sound. Lighting. Bright or very dim lighting can aggravate pain sensation. Eliminate unnecessary interruptions and coordinate care activities, allow for rest. Fatigue increases pain perception. 3. Teach patient how to use pain rating scale. Explain range of intensity scores and how they relate to measure pain. Accurate reporting by patient or family improves ongoing pain assessment, treatment, and evaluation. 4. Prepare and administer appropriate pain-relieving medications, non-opioids, opioids, co-analgesic, or multimodal combination, per healthcare provider's order, see Chapter 20. Choice of medication depends on patient's condition. For example, postoperative pain is often treated initially with opioids or intravenous acetaminophen, which provides effective non-opioid analgesia for postoperative patients. Non-opioids are effective for mild to moderate pain. Patients with chronic pain are typically prescribed multimodal therapy, more than one type of analgesic, for pain relief. 5. Remove or reduce painful stimuli. Reduction of pain stimuli and pressure receptors maximizes responses to pain-relieving interventions. A. Help patient turn and reposition to comfortable position in good body alignment. Reduces stress on musculoskeletal system. B. Smooth wrinkles in bed linens. Reduces pressure and irritation to skin. C. Loosen constrictive bandages, if appropriate to purpose of bandage, or loosen or remove devices, example blood pressure cuff, elastic hose, or sequential stockings. Bandage or device encircling extremity can restrict circulation and cause pain, see Chapter 41. D. Reposition underlying tubes or equipment. Removes pressure on skin. E. Use pillows as needed for alignment and positioning support, see illustration. Step 5e. Positioning patient inside helps maintain position that reduces strain on muscles and pressure areas. 6. Teach patient how to splint over painful side using either a pillow or hand. Splinting reduces pain by minimizing muscle movement at time of stress. A. Explain purpose of splinting. Promotes patient's cooperation. B. Place pillow or blanket over side of discomfort and help patient place hands firmly over area of discomfort, see illustration. Step 6b. Patient shown how to splint painful area. Splinting immobilizes painful area. C. Have patient hold area firmly while coughing, deep breathing, and turning. Splinting decreases movement and subsequent pain during activity. 7. Reduce or eliminate emotional factors that increase pain experiences, see Skill 16.5. Use biopsychosocial treatments, cognitive behavioral and/or behavioral therapies. Helps patients relax. Thoughts influence feelings, which change perception and behaviors, including a perception of pain relief, Baird et al., 2010. Psychological approaches to the management of chronic pain aim to achieve increased self-management, behavioral change, and cognitive change rather than directly eliminate locus of pain, Roditi and Robinson, 2011. A. Offer information that reduces anxiety, example explaining cause of pain if known. B. Offer patient opportunity to pray, if appropriate. Serves as form of distraction. C. Spend time to allow patient to talk about pain and answer questions. Listen attentively. Conveys a sense of caring and interest in patient's welfare. 8. If used, remove and dispose of gloves. Perform hand hygiene. Reduces transmission of microorganisms. Evaluation. 1. Within 1 hour of an intervention, example repositioning or after a medication reaches its peak effect, ask patient to describe level of relief using a scale of 0 to 10. Evaluates effectiveness of pain-relieving interventions in timely manner, Passero and McCaffrey, 2011. 2. Compare patient's current pain with personally set pain intensity goal. Helps to determine appropriate changes to pain management plan. Makes patient active participant in care. 3. Compare patient's ability to function and perform ADLS before and after pain interventions. Contributes to determining effectiveness of pain-relieving interventions, especially in nonverbal patients, APS, 2009, Gloth, 2011, Hare et al., 2011a. 4. Observe patient's nonverbal behaviors. Determines effectiveness of pain-relieving interventions, Hare et al., 2011a. 5. Evaluate for analgesic side effects. Side effects of analgesics may be controlled by reducing dose, increasing time intervals, or administering other medications. 6. Use teach back. We discussed how splinting, turning on your non-surgical side, and relaxation can relieve pain. Explain to me when you can use these approaches at home. Revise your instruction now or develop a plan for revised patient teaching if patient is not able to teach back correctly. Determines patient's level of understanding of instructional topic. Unexpected outcomes. Related interventions. One patient verbalizes continued pain that exceeds pain intensity goal or displays nonverbal behavior reflecting worsening pain. Repeat complete pain assessment. Implement different non-pharmacological pain relief measures. Ask patient and family caregivers which alternatives might be helpful. Notify healthcare provider. 2. Patient experiences unexpected or adverse reaction to medication. Assess unexpected effects on patient. Notify healthcare provider immediately. Be prepared to administer antidote if indicated, example antiemetic, antihistamine, opioid reversing agents such as naloxone. Monitor for effectiveness of antidote. Antidote may have shorter half-life than opioid. Repeat dose of antidote may be needed. Complete adverse reaction documentation according to agency policy. Recording and reporting. Record and report character of pain before an intervention, the pain relief therapies used, any patient or family education provided, and patient response to interventions in nurse's notes in electronic health record, AIR, or chart. Document your evaluation of patient learning. Record and report inadequate pain relief, not reaching goal, a reduction in patient function, and adverse effects from pain interventions, pharmacological and non-pharmacological, in the AIR or chart. Special considerations. Teaching. Review patients' and families' understanding of the pain rating scale used and how to use it when providing pain therapies. Explain to patient and family about the behavioral changes that may result from pain, example change in activity level, splinting a body part, decreased social interaction. Ask patient and family about fear of addiction, a common primary concern, or other misconceptions that could undermine the patient's pain relief. Table 16.1. Table 16.1. Misconceptions, barriers to the assessment and treatment of pain. Misconception. Correction. The best judge of the existence and severity of a patient's pain is the healthcare provider or nurse caring for the patient.
Hell no.
The patient's self-report is the most reliable indicator of the existence and intensity of pain.
Facts.
Clinicians should use their personal opinions and beliefs about the truthfulness of a patient to determine his or her true pain status. Allowing each clinician to act on personal beliefs presents the potential for different pain assessments by different clinicians, leading to different interventions from each clinician. This results in inconsistent and often inadequate pain management. A patient's self-report of pain is the standard for pain assessment. Visible signs, either physiological or behavioral, always accompany pain and can be used to verify its existence and severity. Even with severe pain, periods of physiological and behavioral adaptation occur, leading to periods of minimal or no observable signs of pain. Lack of pain expression does not necessarily mean lack of pain. The pain rating scale preferred for use in daily clinical practice is the Visual Analog Scale, VAS. The preferred pain rating scale depends on a patient's cognitive and physical ability, culture, developmental level, and availability. Cognitively impaired older adults are unable to use pain rating scales. When an appropriate pain rating scale is used and a patient is given sufficient time to process information and respond, many cognitively impaired older adults can use a pain rating scale. If patients hurt enough, they will tell you. Patients are often hesitant to report pain for fear of being labeled as complainers, hypochondriacs, or addicts. Psychosocial interventions alone reduce or alleviate pain. Non-pharmacological interventions are synergistic with medications but are not a substitute for pharmacological management of pain. Pediatric. A numerical rating pain scale is a valid measure for assessing pain intensity in children with chronic pain, Ruskin et al., 2014. The absolute value of a pain intensity score is not as important as the changes in scores in each individual child. In clinical use with individual patients, a change in pain of 2 of 10, i.e., a change of one face, represents the least change that can be considered clinically significant when using a faces scale, Tomlinson et al., 2010. Some children are reluctant to report pain because they have misconceptions about the cause of their pain or they fear the consequences, example another painful procedure or an injection. Infants and children experience pain but respond to it differently than adults. For example, they cry and thrash about, have sleep disturbances, have a shortened attention span, suck or rock, refuse to eat or play, or are quiet and withdrawn. Variations in pain response are related to the child's personality, developmental level, and previous pain experiences. Hockenberry and Wilson, 2015. Parents are helpful when assessing their child's pain and planning pain relief therapies. Most parents know how their child exhibits pain and which pain relief interventions have been successful. Children with verbal skills can rate their level of pain on the Wong-Baker Faces Pain Rating Scale or the Oucher Pain Scale, de Tovar et al., 2010. Gerontological. Older adults who are able to express themselves can use self-report pain scales. In addition, your assessment should include how the pain is affecting function, sleep, appetite, activity, mood, and relationships with others, Tui and Jet, 2014. Some older adults may require more time than younger adults for you to explain a pain assessment scale. Pain is not a natural occurrence of aging, although older adults are at risk for experiencing more pain-producing conditions. Nonverbal older adults experiencing pain typically receive fewer analgesics than similar patients who are able to report their pain, Hare et al., 2011b. Thus be sure that your assessment is thorough and evaluate a patient's response critically. Home care. Consider home conditions such as type of bed and environmental stimuli. A supportive bed and quiet environment enhance sleep and promote pain management. Family caregivers are the main support for older people. Educate them about causes of painful conditions, common misconceptions about use of analgesics, type of pain medicines appropriate for patient, and how to support medication adherence. Cancer pain, tumor growth, and pain associated with bony metastases exemplar. Surgical trauma/postoperative pain exemplar. Skill 16.2 Patient-controlled analgesia. Video clip. Patient-controlled analgesia, PCA, is an interactive method of pain management that permits patient control over pain through self-administration of opioids, usually morphine, hydromorphone, or fentanyl, with minimal risk of overdose. It is a safe method of analgesic administration for acute and chronic pain, including conditions such as postoperative pain, cancer, and end-of-life pain. The goal is to maintain a constant plasma level of analgesic to avoid the problems of PR and dosing. Systemic Pca traditionally involves intravenous, or subcutaneous drug administration. PCA devices are programmed individually to automatically deliver a specific healthcare provider, prescribed continuous infusion, basal rate, of medication, a bolus dose, patient-initiated, or both. PCA prevents overdosing in two ways, having control limits for the total dosage that can be administered each hour and having a timing control, lockout period, that regulates the minimum interval, example 10 minutes between doses, Burcham and Rosenthal, 2016. A patient depresses the button on a PCA device to deliver a regulated dose of analgesic. It is crucial that candidates for PCA be able to understand how, why, and when to self-administer a medication, APS and AAPM, 2009. Monitoring levels of sedation is essential with the use of PCA. This is especially true for most patients who are opioid naive, i.e., those who have never taken opioids for any reason or who have not taken opioids in the past 5 weeks, Passero and McCaffrey, 2011. In addition, oversedation is a risk in patients with obstructive sleep apnea, OSA, brief cessation of respirations during sleep, or obese patients with short, thick, necks who commonly have undiagnosed sleep apnea. Assessment of patient sedation levels is critical, see box 16.4. The advantages of PCA include achieving more constant serum levels of an opioid and avoiding peaks and troughs of a large bolus. Patients receive better pain relief and fewer side effects from opioids because blood levels are maintained at a level of minimum effective analgesia concentration. Increased patient control and independence are other advantages for patients. Because PCA provides medication on demand, the total amount of opioid use can be reduced. Concerns involving PCA use are patient-related, pump failure, or healthcare provider errors. Patients may misunderstand how PCA therapy works, mistake the PCA button for a nurse call button, or have family members operate the demand button. A pump may fail to deliver a drug on demand, have a faulty alarm or low battery, or lack free flow protection. Healthcare providers may incorrectly program a dose, concentration, or rate. Incorrect programming is the most common type of error. Other errors include failing to clamp or unclamp tubing, improperly loading syringe or cartridge, failing to monitor for side effects/overdose, and not responding to alarms. PCA requires careful monitoring. Never try to operate it without fully understanding the particular model in use. Some agencies require a registered nurse, RN, check when initiating a PCA, changing the dose, or discontinuing its use. Delegation and collaboration. The skill of administration of PCA cannot be delegated to nursing assistive personnel, NAP. The nurse directs the NAP to notify the nurse if the patient complains of change in status, including unrelieved pain or oversedation. Notify the nurse if the patient has questions about the PCA process or equipment. Never administer a PCA dose for the patient and notify the nurse if anyone other than the patient is observed administering a dose for the patient. Equipment. PCA system and tubing. Identification label and time tape may come attached and completed by pharmacy. Needleless connector. Alcohol swab. Adhesive tape. Clean gloves, when applicable. Equipment for vital signs and pulse oximeter, or capnography, CO2, monitoring equipment. Step/rationale. Assessment. 1. Check accuracy and completeness of medication administration record, MAR, or computer printout with healthcare provider's order for patient's name, name of medication, dose, frequency of medication, continuous or demand or both, and lockout period. Healthcare provider order required for administration of opioid medication. Ensures that patient receives right medications. To review medication information in drug reference manual or consult with pharmacist if uncertain about any medications to be administered. Understanding medications before administering them prevents medication errors, at Hyperventilation, 2014. 3. Perform hand hygiene. Assess severity and character of patient's pain, see Skill 16.1. Also assess patient's ability to manipulate PCA control and cognitive status for ability to understand purpose of PCA and how to use control device. Reduces transmission of microorganisms. Reveals source and nature of pain and factors that may increase pain. Determines patient's ability to use PCA safely and correctly. 4. Assess environment for factors that could contribute to pain, example noise, room temperature. Elimination of irritating stimuli may help to reduce pain perception. 5. Assess for conditions that predispose patients to unwanted effects from opioids. Known, untreated, or unknown OSA poses a significant risk for respiratory depression, Kraft, 2010. Use the Stop Bang questionnaire to assess for OSA, Lockhart et al., 2013, see agency policy. Assessment should be completed before surgery by anesthesia. Identification allows treatment teams, surgeon, respiratory therapy, anesthesia, to take appropriate precautions such as making continuous positive, airway pressure or bilevel positive, airway pressure ventilation devices available. 6. Apply clean gloves. Assess patency of intravenous, 4, access and surrounding tissue for inflammation or swelling, see Chapter 29. 4. Line needs to be patent for safe administration of pain medication. Confirmation of placement of forecatheter and integrity of surrounding tissues ensures that medication is safely administered. 7. If patient has had surgery, inspect incision, continuing to wear clean gloves. Gently palpate around area for tenderness. Use sterile gloves if necessary to place hand directly on incision. Remove gloves and perform hand hygiene. Reveals evidence of tissue trauma or damage, which stimulates peripheral pain receptors to transmit impulses to cortex to create conscious awareness of pain, Drew and St. Marie, 2011. 8. Check medical record for patient's history for drug allergies and typical reactions. Avoids placing patient at risk for allergic reaction. Clinical decision point. Be aware that nausea is not an allergic reaction and it can be treated. Pruritus alone is not an allergic reaction and is common to opioid use. Pruritus is treatable and does not rule out the use of PCA. 9. Assess patient's knowledge and perceived effectiveness of previous pain management strategies, especially previous PCA use. Response to pain control strategies helps identify learning needs and affects patient's willingness to try therapy. Nursing diagnoses. Acute pain. Anxiety. Chronic pain. Deficient knowledge regarding use of PCA. Fear. Ineffective coping. Impaired physical mobility. Related factors are individualized based on patient's condition or needs. Planning. 1. Expected outcomes following completion of procedure. Patient verbalizes pain relief. Subjective measure of pain relief. Patient rates pain lower on pain scale. Objective measure of pain relief. Patient exhibits relaxed facial expression and body position. Nonverbal cues of pain relief. Patient remains alert and oriented. Indicates freedom from overly sedating effects of opioids. Sleepiness is usually from fatigue and not necessarily a sign of oversedation. Patient increasingly participates in self-care activities. Suggests successful pain relief. Patient correctly operates PCA device. Demonstrates safe and appropriate use of PCA. 2. Collect appropriate equipment. Draw curtains around patient's bed or close door to room. Aids in organization. Maintains patient privacy. Privacy. Implementation. 1. Perform hand hygiene. Reduces transmission of infection. 2. Obtain PCA analgesic in module prepared by pharmacy. Check label of medication 2 times, when removed from storage and when preparing for assembly. Follow 6 rights of medication administration to be sure of correct medication. This is the first and second check for accuracy. 3. At bedside identify patient using at least 2 identifiers, example name and birthday or name and medical record number, according to agency policy. Compare identifiers with information on patient's MAR or medical record. Ensures correct patient. Complies with the Joint Commission standards and improves patient safety, TJC, 2016. 4. At bedside compare MAR or computer printout with name of medication on drug cartridge. Have second registered nurse, RN, confirm healthcare provider's order and correct setup of PCA. Second RN should check order and the device independently and not just look at existing setup. Ensures that correct patient receives right medication. This is the third check for accuracy. 5. Before initiating analgesia, explain purpose and demonstrate function of PCA to patient and family caregiver as follows. Allows patient participation in care and independence in pain control. Preoperative education about PCA therapy improves postoperative pain relief. Darcy, 2011, Passero and McCaffrey, 2011. A. Explain type of medication in device. B. Explain that device safely administers self-initiated small but frequent amounts of medication when needed to provide comfort and minimizes side effects from analgesia. C. Explain that self-dosing aids in repositioning, walking, or coughing, and deep breathing. D. Explain that device is programmed to deliver order type and dose of pain medication, lockout interval, and 1 to 4 hour dosage limits. Explain how lockout time prevents overdose. E. Demonstrate to patient how to push medication demand button, see illustration. Instruct family caregiver to not push PCA button to give medication. Step 5E. Patient learn. F. Instruct patient to notify nurse for possible side effects, problems in gaining pain relief, changes in severity or location of pain, alarm sounding, or questions. 6. Apply clean gloves. Check infuser and patient control module for accurate labeling or evidence of leaking. Avoids medication error and injury to patient. 7. Position patient comfortably to be sure that venipuncture or central line site is accessible. Ensures unimpeded flow of infusion. 8. Insert drug cartridge into infusion device, see illustration, and prime tubing. Step 8. Nurse inserting drug. Lock system and prevents air from infusing into 4 tubing. 9. Attach needleless adapter to tubing adapter of patient controlled module. Needed to connect with 4 line. 10. Wipe injection port of maintenance 4 line vigorously with alcohol or antiseptic for 15 seconds and allow to dry. Minimizes entry of surface microorganisms during needle insertion, reducing risk of catheter-related bloodstream infection. 11. Insert needleless adapter into injection port nearest patient, at Y site of peripheral 4 or central line or connect to its own 4 site. There should not be a chance to use PCA tubing for administering 4 push with another drug. Establishes route for medication to enter main 4 line. Needleless systems prevent needle stick injuries. Prevents medication interaction and incompatibility. 12. Secure connection and anchor PCA tubing with tape. Label PCA tubing. Prevents dislodging of needleless adapter from port. Facilitates patient's ability to ambulate. Label prevents error from connecting tubing from different device to PCA. 13. Program computerized PCA pump as ordered to deliver prescribed medication dose and lockout interval. Have second nurse check setting. Note, recheck with oncoming RN during shift handoff to ensure line reconciliation. Ensures safe, therapeutic drug administration. With appropriate dose intervals, example 10 minutes, usually an appreciable analgesic effect and / or mild sedation is achieved before patient can access the next dose, thus there is lower chance for oversedation and respiratory depression. Kraft, 2010. 14. Administer loading dose of analgesia as prescribed. Manually give one-time dose or turn on pump and program dose into pump. Establishes initial level of analgesia. 15. Discard gloves and supplies in appropriate containers. Dispose of empty cassette or syringe in compliance with institutional policy. Perform hand hygiene. Reduces transmission of microorganisms. The Federal Controlled Substances Act regulates control and dispensation of opioids for all institutions. 16. If experiencing pain, have patient demonstrate use of PCA system. If not, have patient repeat instructions given earlier. Repeating instructions reinforces learning. Checking patient's understanding through return demonstration helps you determine patient's level of understanding and ability to manipulate device. 17. Be sure that venipuncture or central line site is protected and rechecked before leaving patient. Ensures patency of 4 line. 18. To discontinue PCA. A. Check healthcare provider order for discontinuation. Obtain necessary PCA information from pump for documentation, note date, time, amount infused and amount of drug wasted and reason for wastage. Ensures correct documentation of a Schedule II drug. 2. RNS must witness wastage of opioids, narcotics, and sign record to meet requirements of the Controlled Substances Act for scheduled drugs. B. Perform hand hygiene and apply clean gloves. Turn off pump. Disconnect PCA tubing from primary 4 line but maintain 4 access. Reduces transmission of infection. Ensures continuation of 4 infusion. C. Dispose of empty cartridge, tubing, and gloves according to agency policy. Evaluation. 1. Use pain rating scale to evaluate patient's pain intensity following treatments and procedures according to agency policy. Determines response to PCA dosing. Documenting PCA in use or PCA effective is not an adequate record of patient's pain level. 2. Observe patient for nausea or pruritus. Common side effects of opioid. 3. Monitor patient's level of sedation, vital signs, and pulse oximetry or capnography every 1 to 2 hours for first 12 hours, APS and AAPM, 2009. Monitor more often at start, during first 24 hours, and at night when hypoventilation and hypoxia tend to occur, Ramachandran et al., 2011. Follow agency policy. Patient is at highest risk the first 24 hours of use. Excess sedation, difficult to arouse, precedes respiratory depression. 4. Have patient demonstrate dose delivery. Evaluate skill in use of PCA. 5. According to agency policy, evaluate number of attempts, number of times patient pushed button, delivery of demand doses, number of times drug actually given and total amount of medication delivered in particular time frame, and basal dose if ordered. Helps to evaluate effectiveness of PCA dose and frequency in relieving pain. Maintains compliance with Controlled Substances Act. 6. Observe patient initiate self-care. Demonstrates pain relief. 7. Use teach back. I want to be sure I explained how PCA will help with your pain and how you should use the device. Tell me the steps you will use to activate the PCA. Revise your instruction now or develop a plan for revised patient teaching if patient is not able to teach back correctly. Determines patient's level of understanding of instructional topic. Unexpected outcomes. Related interventions. 1. Patient verbalizes continued or worsening discomfort or displays nonverbal behaviors indicative of pain. Perform complete pain reassessment. Assess for possible complications other than pain. Inspect foresight for possible catheter occlusion or infiltration. Evaluate number of attempts and deliveries initiated by patient. Check that maintenance of fluid is running continuously. Evaluate pump for operational problems. Consult with healthcare provider. 2. Patient is sedated and not easily aroused. Stop PCA. Notify healthcare provider. Elevate head of bed 30 degrees unless contraindicated. Instruct patient to take deep breaths. Apply oxygen at 2L/min per nasal cannula, if ordered. Assess vital signs, oxygen saturation, and/or capnography. Evaluate amount of opioid delivered within past 4 to 8 hours. Ask family members if they pressed button without patient's knowledge. Review MAR for other possible sedating drugs. Prepare to administer an opioid reversing agent. Observe patient frequently, APS, 2009. 3. Patient unable to manipulate PCA device to maintain pain control. Consult with healthcare provider regarding alternative medication route or possibly a basal, continuous, dose. Recording and reporting. Record drug, concentration, dose, basal and/or demand, time started, lockout time, amount of solution infused, and remaining solution in the electronic health record, AIR, or chart. Many agencies have special PCA documentation forms. Record regular assessment of patient response to analgesia on PCA medication form, in nurse's notes in electronic health record, AIR, or chart, on pain assessment flow sheet, or on other documentation according to agency policy. This includes vital signs, oximetry or capnography, sedation status, pain rating, and status of vascular access site. Document your evaluation of patient learning. Special considerations. Teaching. Give instructions during pain-free or pain-reduced states and before initiating therapy. Instruct surgical patients before surgery. Encourage patients to push button on timing unit at the earliest indication of pain. Teach preemptive pain management. Explain regimen to family so they can support and coach patient, but not push button for patient. Inform patient of non-pharmacological pain management strategies that supplement or enhance pharmacological intervention, see Skill 16.5. Inform patient and family that patient will not overdose with PCA if only the patient pushes the button. Pediatric PCA is an effective means of pain control in children who can understand the concept. When selecting children for PCA use, consider a patient's developmental level, cognitive level, and motor skills. Ordinarily PCA use is safe and effective for patients as young as 5 years old, Detovar et al., 2010. From a developmental perspective, use of PCA is particularly effective with adolescents because it leads to feelings of control. Although controversial, some agencies have provided specific guidelines and training to allow parents and nurses to push the button for children too young or unable to use the device on their own. When this is allowed, the concept of patient control is negated, and the inherent safety of PCA needs to be monitored. Hockenberry and Wilson, 2015. Pharmacological pain support is safe and effective in pediatric patients when dose is calibrated according to child's weight. Kleber et al., 2011. Gerontological. Older patients sometimes appear more sensitive to analgesics and experience more opioid side effects. Gloth, 2011. Older adults' reduced renal and liver function slows opioid metabolism and excretion. This causes a faster peak effect and a longer duration of action of the opioid. Dosages should be started low and titrated upward slowly until pain relief is achieved. Drew and St. Marie, 2011, Gloth, 2011. If patient confusion occurs while using PCA, call to get orders to lower the dose, lengthen the lockout, or add a non-opioid analgesic to reduce the opioid dose. Nurse-activated around-the-clock dosing is another alternative. Refusing to medicate is not the answer. Confusion may be caused by pain, not the medications. Passero and McCaffrey, 2011. Labor pain. Skill 16.5 Non-Pharmacological Pain Management. Video clip. Effective pain management does not always mean the elimination of pain. A variety of non-pharmacological therapies are available to directly lessen a patient's pain and provide additive relief when analgesics are administered. Non-pharmacological interventions can be used in any healthcare setting. These interventions are classified as complementary or alternative therapies, and there is evidence of their efficacy in providing pain relief. NIH, 2015a. Use these interventions in combination with pharmacological interventions, not in place of them. Non-pharmacological techniques diminish the physical effects of pain, alter a patient's perception of pain, and provide a patient with a greater sense of control. Non-pharmacological interventions are appropriate for patients who find such interventions appealing, express anxiety or fear, may benefit from avoiding or reducing drug therapy, and have incomplete pain relief with pharmacological interventions alone. You will be able to help patients control their pain by teaching them to add a variety of non-pharmacological techniques for self-care. Box 16.5. Patients and families today are more aware of complementary techniques and should be encouraged to continue whatever has worked for them. Because everyone responds differently, finding new methods that work for a patient may take more time than finding pharmacological techniques. Box 16.5. Non-pharmacological strategies for pain management *. Relaxation and power of the mind. Self-comfort. Progressive muscle relaxation. Autogenics training. Breathing exercises. Music relaxation. Visual imagery. Yoga. Put your body to work. Exercise. Pacing. Relaxation and guided imagery. Relaxation and guided imagery help to relieve acute and chronic pain, anxiety, and depression. Deep, slow breathing associated with relaxation performed alone or in combination with the focused concentration of guided imagery influences autonomic and pain processing, essential features in the modulation of sympathetic arousal and pain perception. Bush et al., 2012. Relaxation has been shown to be effective in reducing postoperative pain from upper abdominal surgery and labor pain. Jones et al., 2012, Topku and Feindick, 2012. A patient's full participation and cooperation are necessary for relaxation techniques to be effective. Relaxation and guided imagery provide patients with self-control when pain occurs. In guided imagery, a person draws on personal memories, dreams, and visions to create an image in the mind, concentrates on that image, and gradually becomes less aware of pain. Focus of the imagination helps patients change their perceptions about their disease, treatment, and healing ability, which helps relieve pain, tension, or stress. Choosing images that patients find pleasant requires a careful assessment. Otherwise you may mistakenly describe images of objects or things that a patient fears or dislikes. Baird et al., 2010. For example, a scene of rolling waves at the seashore is restful to one patient but may be frightening to another. The technique has been shown to be effective in improving the functional status and sense of self-efficacy for managing pain and other symptoms of fibromyalgia. Menzies et al., 2006. Cutaneous stimulation. Massage. A gentle massage, a form of cutaneous stimulation, is the application of touch and movement to muscles, tendons, and ligaments without manipulation of the joints. A proper massage not only blocks perception of pain impulses but also helps relax muscle tension and spasm that otherwise might increase pain. Massage therapy can produce a relaxation response that creates a calm state and enhances the ability to rest. Adams et al., 2010. Massage hastens the elimination of waste stored in muscles, improves oxygenation of tissues, and stimulates the relaxation response in the nervous system. In a study involving a small sample of medical, surgical, and obstetrics inpatients, massage was shown to reduce patients' actual pain levels, but the study also revealed a relationship among pain, relaxation, sleep, emotions, recovery, and the healing process. Adams et al., 2010. A superficial massage of the back, shoulders, and lower part of the neck is sometimes referred to as a back rub. Offering a back rub after a bath or before a patient prepares for sleep promotes relaxation and comfort. An effective back rub takes 3 to 6 minutes and is an important intervention for decreasing pain and improving sense of well-being. Heat and cold. Heat and cold applications are applied to the skin to relieve pain and promote healing by improving circulation and reducing edema. The selection of heat versus cold varies with a patient's preference and condition. The application of heat or cold in a healthcare agency or home health environment requires a healthcare provider's order. Although the physiological responses to heat and cold differ, superficial heat or cold applications provide comfort in conditions such as muscle spasms, strains, and localized joint pain. See Chapter 42 for a review of warm and cold therapy. Distraction. Distraction is a technique that diverts an individual's attention away from mild or moderate pain sensation. It can be used alone to manage mild pain or with analgesics to manage brief bouts of severe pain such as pain related to procedures. ONS, 2015. By introducing meaningful stimuli, you help a patient consciously attend to only one stimulus, thus diverting the attention away from pain. There are internal and external distraction techniques. Internal techniques include having patients count, sing to themselves, pray, or repeat statements in their head such as I can cope. ONS, 2015. External distractions include changing a patient's activity, needlework, listening to music, reading, walking, playing a musical instrument, or watching a comedy program. NIH, 2015a. Therapeutic communication with a nurse is another example of distraction. When the distraction is removed, a patient may have a heightened awareness of pain. Delegation and collaboration. Assessment of a patient's pain cannot be delegated to nursing assistive personnel, NAP. The skill of non-pharmacological pain management strategies can be delegated to NAP. The nurse directs the NAP by identifying and explaining which non-pharmacological measures work best for a patient. Explaining how to adapt strategies to patient restrictions, example massage in side-lying versus prone position. Instructing to report worsening of a patient's pain. Equipment. Step/rationale. Assessment. 1. Assess patient's language level and values he or she has regarding alternative pain relief approaches. Identify descriptive terms that you will use when guiding patient through relaxation or guided imagery. Ensures that care is culturally appropriate. Establishes connection with patient to enhance your ability to guide relaxation. 2. Assess character of patient's pain, see Skill 16.1, and review findings to consider cause for pain. Establishes baseline to determine effects of intervention. Helps determine if non-pharmacological approaches are appropriate. 3. Assess facial expressions, nonverbal indications of discomfort, example grimacing, frowning, voice tone, body position and movement, example restlessness, muscle tension, and patient self-report, see Skill 16.1. Serves as baseline to evaluate effectiveness of pain relief measures. Overt signs and symptoms are usually not present with chronic pain. Physical signs and symptoms indicate change in comfort level. 4. Perform hand hygiene, apply gloves when drainage is present. Examine site of patient's pain or discomfort. Include inspection, discoloration, swelling, drainage, palpation, change in temperature, area of altered sensation, painful area, areas that trigger pain, and range of motion of involved joints, if applicable. Clinical observations may clarify information from patient. Site of discomfort may direct you to specific types of pain relief measures. 5. Assess character of patient's respirations. Establishes baseline. Relaxation techniques focus on breathing. 6. Review healthcare providers' orders for pain relief, if required by agency. In some acute care settings, a medical order is necessary to perform non-pharmacological therapies. 7. Assess patient's understanding of pain and willingness to receive non-pharmacological pain relief measures. Participation increases effectiveness of pain relief measure. If patient is reluctant to try activity, provide information about suggested therapy. 8. Assess preferred patient activities, example puzzles, crocheting, game on electronic device, board games, music, or relaxation tape. Improves likelihood of distraction being effective. 9. Assess type of image patient would prefer to use in guided imagery. Prevents use of image that could frighten patient. 10. Review any restrictions in patient's mobility or positioning. Determines whether massage is appropriate and positioned to have patient assume. Nursing diagnoses. Activity intolerance. Acute pain. Anxiety. Chronic pain. Deficient knowledge regarding non-pharmacological methods of pain control. Ineffective coping. Powerlessness. Related factors are individualized based on patient's condition or needs. Planning. 1. Expected outcomes following completion of procedures. Patient demonstrates and describes pain relief measures. Demonstrates patient understanding and learning. Patient is relaxed and comfortable after technique as evidenced by slow, deep respirations, calm facial expressions, calm tone of voice, relaxed muscles, relaxed posture. Non-pharmacological strategies help patient relax and experience less discomfort. Physiological response to relaxation procedures and massage is deep relaxation. Patient reports pain relief on 0 to 10 scale. Patient's subjective report is most reliable indicator of presence of pain. 2. Explain purpose of technique and what you expect of patient during activity. Explain how to use pain rating scale, skill 16.1. Proper explanation of activity enhances patient participation. Accurate reporting of pain by patient improves your evaluation and treatment. 3. Set mutual pain intensity goal with patient, when able, for rest and during routine care activities. Patient sets individual goal for tolerable pain severity. 4. Plan time to perform technique when patient is able to concentrate, example after voiding, awakening from nap. Increases opportunity for success. 5. Administer an analgesic 30 minutes before implementing a non-pharmacological therapy. Patient is able to gain a level of comfort needed to perform non-pharmacological therapies. Implementation. 1. Perform hand hygiene and prepare patient's environment. Reduces transmission of microorganisms. Temperature suited to patient. Sound. Lighting. Minimize interruptions and coordinate care activities, allow for rest. Temperature and sound extremes can enhance patient's perception of pain. Bright or very dim lighting can aggravate pain sensation. Fatigue increases pain perception. 2. Massage. Clinical decision point. Massage is contraindicated in cases of muscle, bone, or joint injury, bruised, swollen, or inflamed areas. A. Place patient in comfortable positions such as prone or side lying. Have patients with difficulty breathing lie on side of bed with head of bed elevated. Enhances relaxation and exposes areas to be massaged. B. Adjust bed to comfortable position for you, lower upper side rail on side where you are standing. Drape patient to expose only area that you will massage. Ensures proper body mechanics and prevents strain on back. C. Turn on music to patient's preference. Promotes relaxation. D. Ensure that patient is not allergic to lotion, warm lotion in hands or in basin of warm water. Note, if you massage head and scalp, delay use of lotion until completed. Warm lotion is soothing, and warmth helps to produce local muscle relaxation. E. Choose stroke technique based on desired effect or body part. Ensures fuller relaxation of body part. Clinical decision point. Use very gentle massage with patients who are unable to communicate because they cannot tell you if massage becomes uncomfortable. Comfortable. 1. Effleurage, massaging upward and outward from vertebral column and back again, see illustration. Step 2E, 1. Effleurage. Light, gliding stroke used without manipulating deep muscles smooths and extends muscles, increases nutrient absorption, and improves lymphatic and venous circulation. 2. Petrisage, see illustration. Step 2E, 2. Petrisage. Kneading tense muscle groups promotes relaxation and stimulates local circulation. 3. Friction. Strong circular strokes bring blood to surface of skin, increasing local circulation and loosening tight muscle groups. F. Encourage patient to breathe deeply and relax during massage. Potentiates effects of massage. G. Standing behind patient, stimulates scalp and temples. H. Supporting patient's head, use friction to rub muscles at base of head. Strong circular strokes, friction, stimulate local circulation and relaxation. I. Reposition if needed. With patient in supine position, massage hands and arms as appropriate, Psychosocial, 2011. Releases tension in hands and arms. Studies indicate that anxious behaviors may be reduced significantly with hand massage, Psychosocial, 2011. 1. Support hand and apply friction to palm using both thumbs. 2. Support base of finger and work each finger in corkscrew-like motion. 3. Complete hand massage using effleurage strokes from fingertips to wrist. 4. Knead muscles of forearm and upper arm between thumb and forefinger. Encourages relaxation, enhances circulation and venous return. J. After determining that patient has no neck injury or condition that contraindicates neck manipulation, massage neck as appropriate. 1. Place patient prone unless contraindicated. Provides access to neck muscles. 2. Knead each neck muscle between thumb and forefinger. Reduces tension that often localizes in neck muscles. 3. Gently stretch neck by placing one hand on top of shoulders and other at base of head. Gently move hands away from one another. Helps relax muscle body. K. Massage back as appropriate. Patient with back injury, surgery, or epidural infusion should not receive back massage. 1. Assist patient to prone position unless contraindicated, side lying position is option. Provides access to muscle groups in back. 2. Do not allow hands to leave patient's skin. Continuous contact with surface of skin is soothing and stimulates circulation to tissues. Breaking contact with skin can startle patient. 3. Apply hands first to sacral area, massage in circular motion. Stroke upward from buttocks to shoulders. Massage over scapulas with smooth, firm stroke. Continue in one smooth stroke to upper arms and laterally along sides of back down to iliac crest, see illustration. Continue massage pattern for 3 minutes. General, firm pressure applied to all muscle groups promotes relaxation. Step 2K, 3. Circular massage of the back. 4. Use effleurage along muscles of spine in upward and outward motion. Massage follows distribution of major muscle groups. 5. Use Petricage on muscles of each shoulder toward front of patient. Area often tightens because of tension. 6. Use palms in upward and outward circular motion from lower buttocks to neck. Brings blood to surface of skin. 7. Knead muscles of upper back and shoulder between thumb and forefinger. These muscles are thick and can be massaged vigorously. 8. Use both hands to knead muscles up one side of back and then the other. 9. End massage with long, stroking effleurage movements. Most soothing of massage movements. L. Massage feet as appropriate. 1. Place patient in supine position. Returns patient to comfortable anatomical position. 2. Hold foot firmly. Support ankle with one hand or support sides of foot with each hand while performing massage. Maintains joint stability during massage, Assaydisker et al., 2011. 3. Make circular motions with thumb and fingers around bones of ankle and top of foot. All massage strokes help to relax muscles. 4. Trace space between tendons with firm finger pressure, moving from toe to ankle. 5. Massage sides and top of each toe. 6. Use top of fist to make circular motions on bottom of foot. 7. Knead sides of foot between index finger and thumb. 8. Conclude with firm, sweeping motions over top and bottom of foot. 2 light strokes may tickle. M. Tell patient that you are ending massage. Informs and prepares patient to inhale and exhale deeply. And when procedure is complete, instruct patient to inhale deeply and exhale. Caution him or her to move slowly after resting a few minutes. Returns patient to more awake and alert state. When deeply relaxed, patient may experience dizziness on arising too rapidly and need time for vessels to redistribute blood supply. O. Wipe excess lotion or oil from patient's body with bath towel. Excess lotion or oil can irritate skin and lead to breakdown. P. Return bed to low position and raise side rails as appropriate when massage is finished. Perform hand hygiene. Side rails cannot be used as a restraint. 3. Progressive relaxation with deep breathing. A. Have patient assume comfortable sitting position, sit with feet uncrossed or lie in supine position with small pillow under head. Maximizes ability to relax. B. Instruct patient to take several slow, deep, diaphragmatic breaths. It may help to have patient close his or her eyes. Increased oxygen lessens anxiety and prevents shortness of breath with relaxation breathing technique. Avoids hyperventilation. Eye closure maintains patient focus on exercise. C. Explain as follows: the air coming in through your nose should move downward into your lower belly. Let your belly expand fully. Now breathe out through your mouth, or your nose, if that feels more natural. Alternate normal and deep breath several times. Pay attention to how you feel when you breathe in and breathe out normally and when you breathe deeply. Shallow breathing feels tense and constricted, while deep breathing helps you relax. Patient able to focus on exercise with your coaching. Becoming mindful of how body feels can enhance relaxation. D. Continue the exercise. To practice, put one hand on your abdomen, just below your belly button. Feel your hand rise about an inch each time you breathe in and fall about an inch each time you breathe out. Your chest will rise slightly, too, along with your belly. Remember to relax your belly so that each time you breathe in, it expands fully. As you breathe out slowly, let yourself sigh out loud. Allows patient to master slow deep breathing. E. Observe patient and caution against hyperventilation. Causes patient to eliminate more carbon dioxide than is produced, and consequently results in respiratory alkalosis and an elevated blood pH. Patient becomes dizzy and lightheaded. F. Coach patient to locate any area of muscle tension and alternate tightening and relaxing all muscle groups for 6 to 7 seconds, beginning at feet and working upward toward head. Relaxation is an integrated response associated with diminished sympathetic nervous system arousal. Decreased muscle tension is desired outcome. 1. Instruct patient to tighten muscles during inhalation and relax muscles during exhalation. Relaxation decreases pulse and respiration rates, and blood pressure and helps reduce anxiety. Baird et al., 2010. 2. As each muscle group relaxes, ask patient to enjoy relaxed feeling and allow mind to drift and think how nice it is to be relaxed. Have patient breathe deeply. Allows opportunity to enjoy feelings of relaxation. 3. Calmly explain during exercise that patient may feel sensations of tingling, heaviness, floating, or warmth as relaxation occurs. Prevents anxiety if sensation occurs without warning. 4. Have patient continue slow deep breaths throughout exercise. 5. When finished, have patient inhale deeply, exhale, and then initially move about slowly after resting a few minutes. Returns patient to more awake and alert state. Rising too rapidly can cause dizziness. 4. Guided imagery. A direct patient through guided imagery exercise while having him or her focus on an image. Example follows. 1. Instruct patient to imagine that inhaled air is ball of healing energy. Developing specific images helps to remove pain perception. 2. Imagine that inhaled air travels to area of pain. Patient's ability to concentrate decreases pain perception. B. Alternatively, you may direct imagery. 1. Ask patient to imagine a pleasant place such as beach or mountains. Choose an image peaceful for patient. Directs imagery after selection of restful place. 2. Direct patient to experience all sensory aspects of restful place, example for beach, warm breeze, warm sand between toes, warmth of sunshine, rhythmic sound of waves, smell of salt air, gulls gliding and swooping in air. Helps patient concentrate and relax through stimulation of numerous senses, Baird et al., 2010. Make sure that it is something in their experience, not just yours. 3. Direct patient to continue deep, slow, rhythmic breathing. Promotes relaxation through muscle relaxation. 4. Direct patient to count to 3, inhale, and open eyes. Suggest that patient move about slowly initially. C. Provide patient time to practice.